I've been here in Tucson for 16 years at this point. My last stop on the road was my fellowship training program at Oregon Health Sciences University. And as Jaime said, my focus there was what we call functional neurosurgery. Now that's a kind of an esoteric term that really deals with how to maximize function for specific types of diseases. One of the main ones that I focused on in my training is Parkinson's disease, tremor, and movement disorders. And so before we start, there's a couple of things we need to say. First, I need to give my disclosures, and that is what we do when we talk about this is people always ask, oh, do you work with the various companies that make the products that go into patients? And the answer to that question is I work closely with them, but I have no real financial ties to them. And so this is a fairly objective talk on Parkinson's disease and tremor. The important thing to note, though, is that both Tyler Plumbo from Abbott and Joey Gregan from Medtronic have been instrumental in helping us get this organized and get the large turnout that we have here today. And of course, the Carondelet Neurologic Institute and Carondelet in general, we're very grateful for them to allow us the space and the time to have this kind of conversation. So DBS, or Deep Brain Stimulation, what is that all about? Well, what a deep brain stimulator is, it's an implantation of an electrode into one or more target areas in the brain to change the way the brain behaves. The brain is a big electrical system, and as we'll get further on into this talk, you'll see that what we've discovered as we've done various surgeries on the brain, we've witnessed various kinds of strokes and tumors, we've started to map out how the electrical system of the brain is put together. And with that, of course, came, well, what can we do to influence the way the brain behaves? And as technology has gotten better and technology has gotten smaller and more reliable, we've been able to put electrical systems into the brain for a number of different disorders. And of course, the one that many of us are here to talk about today is the two most common ones, which are Parkinson's disease and essential tremor. But to kind of give you perspective, there are a number of disorders that deep brain stimulators go in for. Dystonia, which is another movement disorder, and then the psychiatric disorders such as obsessive compulsive disorder, Tourette's syndrome, depression, and epilepsy. So there's quite a host. We also put them in for pain problems, sometimes for stroke issues, post-stroke issues, and that kind of thing. So Parkinson's disease. Again, the physiology of Parkinson's disease and what a deep brain stimulator does. As many of you know, Parkinson's disease, the nerve cell is responsible for sending signals to control movement and coordination, malfunction over time, and start to die. That the deep brain stimulator is, in general, trying to work as a way to restore balance to this system. The stimulator doesn't really change the brain tissue or stop the disease progress, and I use this slide for some of the electricians or electrical engineers or mechanical engineers in the crowd. This is what we think of as the circuit diagram for movement disorders in Parkinson's disease. This little black area in the center is the substantia nigra. Those are the cells that produce dopamine, and they generate two different types of output. The end product of all of this is this little line here. This whole system kind of goes up to the thinking part of your brain and then down to your spinal cord to make you move. And so when the system gets out of balance, that is, if we were to sort of take away some of that input, you notice that a lot of the arrows change. And I'm going to toggle back and forth here for a little bit. But if you look at that little gray SNC there in the center, it goes from having a relatively small output arrow called D2 and a fairly balanced D1 and D2 over here, which are their two outputs, to a big arrow on your left and a smaller arrow on your right. And the end output there is that you get less ability to move. And so what somebody figured out is if you have this misbalance in the system, you have a lot of other little nodes, if you will, a lot of little other places that you can affect the output of this system. And if you change the way those behave, then you can change the overall outflow for this movement control. And so one way might be to take this little guy down here called the subthalamic nucleus, which is a favorite target of ours for Parkinson's disease, and knock him out. And we learn this by strokes. So if you take that out, you sort of restore the balance. The green arrows get bigger and movement becomes easier. What you've done is now take out 2 nodes. And what a deep brain stimulator does is, in a very similar fashion, it will help restore the balance by inhibiting some of these nodes from acting in the way they normally would and sort of reorganizing the balance to the system. So how did we get there? Well, the easy answer is that, again, through discoveries resulting mostly from surgeries and strokes and observation over time, starting in the 30s and going up to the 60s, we started to learn that stimulating different areas of the brain with high-frequency electricity or by causing strokes or by manipulation can cause a change in systems. And that developed a prototype that became available in the 70s. And the point of this slide is really, people always ask me, how long has this been around? It feels like it's really new. It's not really all that new. It's been around for quite a while. You don't hear much about it because it's a bit of an esoteric area of medicine. There's not a lot of folks that suffer from the disorder that then over time, especially in the 70s and 80s, and now as people are living longer, it's becoming more and more prevalent. Information is much more readily available, and so now you're hearing about it, but we've been doing it for quite a while. Then over the ensuing years, we've had essentially a product stabilization, standardization, and then now another innovation cycle where we're getting more and more technologies available. This is what a deep brain stimulator looks like. It's a lead that goes into the brain and then is affixed so that the lead does not move by a little cap on the skull. And then a wire travels down underneath the skin and is connected to a battery. Traditionally, there were batteries, one on each side. Now, more commonly, we have one battery that drives the whole thing and both wires go to it. Typically, there will be leads on both sides of the head, so both right and left. Most of the movement disorders that people suffer from are bilateral. It is sometimes the case that we will put a lead on one side and not on the other. There are reasons for that, and we'll get into it a little bit here in just a minute. So I want to kind of educate you about the who, what, wheres, and hows of deep brain stimulators. We want to talk a little bit so that you can kind of get your head around whether this might be something you want to learn more about, who we do surgery on, and then if that sort of moves into your sphere of influence, that's something that you're interested in, what it is, what it means to say the word target, what side, one side, both sides, what it means to have it done in one sitting or 2 sittings, why we sometimes do these things awake and asleep, and just kind of give you an overall idea of what it's about. And then, of course, when, because when you have one of these problems, it's too early, too late, when do I do this, when do I need to think about this? And then the why. Now, I'm going to start actually with the why, because the why is the easiest question for us to answer. Why do deep brain stimulation surgery? Why do brain surgery for Parkinson's disease? Many of you saw the Robert De Niro, Robin Williams film back in the day where they discovered carbidopa, levodopa, and medication works really well for Parkinson's disease, especially in the early stages of the disease. So why would anybody want a brain surgery if medicine works well? Well, the easy answer is that through a number of studies, we've been able to determine that DBS is superior to best medical management for the treatment of what we call on-off fluctuations in well-selected moderate to advanced Parkinson's patients. So let me break that down for you. On-off fluctuations, many of you who suffer from Parkinson's disease will notice that your performance goes up and down throughout the day. That is, you take some medicine and you get better, and sometimes you get a little bit too movie. In other words, you move a little bit too much. And then as that medicine wears off, you kind of go through this period where you're better again, and then you kind of bottom out for a while, and you take another pill and you go back up. And what happens over time is the number of medication treatments required during the day to make that happen increases as the disease progresses. And so you kind of go from a rolling swell of an ocean to start with big waves. And then when the big waves get closer together, you're suffering, your window where you're actually performing well gets smaller. We call those on-off fluctuations. So the easy answer is why? Why is because it works. It works well. It gives people better quality of life. And then the goal of this, the art of this, is to try to figure out the who, what, and where. Who, when, and what. Those become the predictor of who's going to do well with this kind of surgery. Keeping in mind that at least at this point, we don't have a cure for Parkinson's disease. Now, essential tremor, and I'm going to say a little word about that. We're sort of talking about two different things. Essential tremor is obviously not Parkinson's disease. We also do not have a cure for essential tremor. We're not as clear about why essential tremor occurs. And again, it's not one of these things that we can fix. What we're trying to do is ameliorate the symptoms of the disease to get a better functional outcome. And so that requires kind of a thoughtful, individualized approach. You sort of have to look at what you've got in front of you for a patient and try to figure out what the various competing things are and how you can help them best, balancing, where they're at in their disease, where they're at in their overall health, what their cognition is like, and these kind of things. So just up front for Parkinson's disease, the things that DBS works great for are tremor, rigidity, bradykinesia, which is slowness of movement, lack of movement or akinesia, and dyskinesia, which is that writhing snake-like movement that you sometimes get when you're at the very tip of that medication dose. We don't do as well with things like speech dysfunction, swallowing, micrographia. Gait and instability are tricky for us, and I explain this to my patients pretty straightforwardly. Gait and postural stability, meaning being able to stand upright, is a really complicated thing. It seems simple because you've been doing it since you were 1.5. But your nerves in your feet have to work right. The spine has to be able to transmit those nerves to a part of your brain called the cerebellum, and that has to work right. And it has to communicate with the rest of your brain appropriately. And then all of that stuff, once it's communicated up here, has to be able to get back down to your feet to allow you to stay upright in a microsecond. And what often happens as folks get various problems in various parts of this system is that the signal just doesn't get up there fast enough or doesn't get back down fast enough. And so it's like your brain is always acting on information that's just a little bit too old. And so, you need to put our feet here, but by the time it gets up and down, your weight has shifted, your posture has shifted, and it's not an appropriate response, and therefore you're off balance. What we do really well for, again, it improves what we call your motor score, which is the score we use to evaluate Parkinson's function in the off-medication state, and it delivers increased on time without the troublesome dyskinesias, up to 4.6 hours a day. It improves motor symptoms better than medication alone, and it's effective for 10 years or greater. Now, the nice thing about a deep brain stimulator is it's not a one-shot kind of a gig. It's actually got sort of a dimmer switch like on your dining room light. We can turn these things on or off, up or down. We can change how the electricity is being delivered. We can kind of change where the electricity is being delivered. And through that, we can craft, as your disease progresses, increased effects so that if your disease is kind of getting away from us again, we can often manipulate the deep brain stimulator current to be able to capture that effect again. So it can change with you. It's not sort of like you put this in and you're done. Part of the way that this was discovered is in the old days, that's exactly what they did. They put it in, and rather than leave a wire in, they burned a little hole in the brain. They created a tiny little stroke. And that was effective for a while, but of course then the disease progresses and they've already done that and they can't undo that. And so the stimulator is designed, again, to sort of help us craft what's right for you as things progress. So, are there other alternatives to deep brain stimulator surgery? The answer is yes. Of course, many of you know of the medication therapies, and it's true that you certainly don't want to lead with brain surgery, right? So the medication therapies have their place. And in fact, we would tell you that you should try a variety of medications. Not one cocktail works for every patient. There are a number of drugs out on the market, and the neurologists, particularly some of the movement disorder neurologists, are very skilled at kind of creating this cocktail of medications that can keep folks functioning very well for quite some time. So you don't want to lead with brain surgery. But when the medications start to be less effective, that is, you start to get these big fluctuations, or you start to get a lot of side effects or other things that can influence, there are some investigational options regarding continuous drug deliveries. Of course, they're always trying to get the newest in genetic or stem cell trials, trying different targets with DBS. But the bottom line answer is, at least at this point today, all of those are mostly research oriented. There are a variety of things that people can try. You can get into different studies. You can have some innovation from the movement disorder neurologist. But there's no easy way to compare on a large-scale basis, what's going to work well. And one of the benefits of having a DBS so widely available is we've been able to do those comparisons to some of the standard medications, and we know that this surgery works. So if why is the easy, obvious thing for me to answer, then the art of medicine comes with who, right? So who, we have to start talking about chronologic versus physiologic age. And as time goes on, chronologic age has become less important. What do we mean by that? Well, people are living longer. And not only are they living longer, they're living healthier longer. So when we were doing studies 10 or 15 years ago, 70 was considered old. It doesn't take very long walking around in southern Arizona to realize that 70 is not all that old. And there are some 70-year-olds that, are quite a bit more active than I am. And so when you do this, you can't just sort of use 70 as a clinical cutoff. You need to take into account other medical problems, other issues such as dementia. You want to take into account things like brain atrophy, psychological factors, and the effect of medications and DBS on mood. Now, again, a lot of these Parkinsonian medications have significant side effects, and some of them affect some people greater than others, particularly as that population gets older. So, dementia. Dementia is one of the ones that will kind of intimidate your surgeon a little bit. And the reason for that is that if it's present, there's a possibility with any surgery, but of course an increased possibility with brain surgery and deep brain stimulation surgery in particular, that the cognitive deficits may worsen. And that there are some targets that have a little bit more of a hard time with dementia than others. And so it might choose us to choose a GPI target over an STN target. We also know that the brain is really good at making up for deficits on one side in terms of cognition, but all of these surgeries tend to go bilateral. In other words, we put leads in on both sides. And when you do that on both sides of the brain, you can get some interesting side effects. And so in the presence of dementia, some surgeons will pick the worst side and operate on that side, leave the other side alone, hoping that they'll be able to sort of skate around any cognitive issues. One of the ways we try to assess whether or not there's a dementia present or evaluate a patient in that regard is neuropsychological testing and possibly a psychiatric evaluation as well. As you know, many folks, especially in the early stages of dementia, are adept at fooling everybody in the world that there's a problem. And it doesn't come out until you get some solid psychiatric testing or neuropsychological testing. The stuff we're looking for in particular are things like the executive function in speech. Executive function is this fancy way of saying the way you're able to organize your world, how you are able to keep track of where your stuff is, keep your checkbook balanced, be able to communicate with the people in your life like you're supposed to, that kind of thing. So for most people who will undergo deep brain surgery, for everyone in my practice, a neuropsychological evaluation is mandatory. There are some technical aspects that we also like to look at before we consider whether you're a good candidate. One of those is brain atrophy, otherwise known as brain shrinkage. Brain shrinkage is, over time, your brain will naturally lose a little bit of volume. And in some folks, it's more pronounced than others. That is, if you were to look at their brain inside their skull, there's more fluid around the outside than in a younger brain. And it can be uniformly distributed, that is, it all shrinks kind of at the same rate, or it can shrink more in one location than the other. That can pose some technical challenges for surgery, including an increase in bleeding rate or hemorrhage rate, a little bit of difficulty targeting, and difficulty with the proper trajectory. In other words, you want to sort of stay in brain tissue while you're putting these leads in and not go in and out. It's something that we can easily detect on MRI and CT. And so a skilled surgeon will be able to tell you whether or not they feel that the atrophy is going to be a problem, whether or not it's easy to get the leads where they're going to be, or whether you're going to be at increased risk. And it's just something that we discuss with yourselves as patients and with our team prior to surgery. And of course, the last slide I want to talk about, the who's, are psychological factors. There is medications and DBS have effect on emotions and mood. The effect is pretty poorly understood for both mood and cognition. There can be what we call a verbal frequency reduction, that is more difficulty getting the words out. There have been reports of things like depression, aggression, and impulse control. These are all relatively rare, and they tend to happen in folks that have issues that are sort of undiagnosed beforehand. And so that's why the neuropsychological testing is designed to kind of pick those up beforehand so we have an idea of what we're getting into. It doesn't necessarily mean that you can't get it. It just means that we may have to tailor that surgery a little bit differently depending on what we think the cause is, whether it's medication induced or not, whether it's medication responsive or not. We may change the target selection. We may choose to do something on one side rather than on both sides. But the bottom line answer is that this is a team effort. So you have a movement disorder neurologist. Many of you in the room will have one, or your general neurologist who is skilled at doing this. A neurosurgeon, of course, to do the surgery, but then the neuropsychologist, the physical medicine and rehab specialist, a physiatrist, a speech occupational physical therapist, the patient, and then, of course, again, this is Parkinson's disease is not just an isolated person disease. It affects the whole family. Caring for someone with Parkinson's disease, so it is important to get the patient's primary caregiver or whomever, partner, whatever, involved, and as much of the support network as is reasonable. So there's a little bit of a discussion that we need to have about when, and this is an infographic to sort of suggest to folks that there's a window for treatment of with DBS. There's a time at which, when you're initially diagnosed with this problem, that medication works and works well, and we don't really know for every patient how long that's going to go on. But we can see some pretty telltale signs, so that as the medication starts to become less effective, you'll notice that the frequency of medication during the day goes up. Those on-off fluctuations are an indication that the medicine is not going to be as effective long run. And that's when we start to think about whether or not you're going to be a candidate for DBS. On the flip side of that coin, we know that if you don't respond to dopamine, your chances of doing well for a deep brain stimulator are worse. And so there is a time when the Parkinson's disease has progressed too far in order to, that DBS is no longer as feasible. Flip that or contrast that to essential tremor. Essential tremor tends to stabilize over time. You can get pretty darn shaky, but once the disease reaches that stage, it's not as, people don't tend to get worse and worse. And so, as long as it's a clear diagnosis of essential tremor, we would opt to treat them a little earlier. There are no real effective medications for essential tremor. There are things you can try. Mostly they're blood pressure medications, and they have the side effect that they worsen people's blood pressure and sometimes cause them to faint. And so essential tremor is a little bit of a different animal when we talk about deep brain stimulation surgery. So when? Well, it's important to keep in mind that it's not a disease-modifying surgery. That is, it does not change the trajectory of the disease. The Parkinson's disease is occurring because cells are dying in a part of the brain, and we're not doing anything to reverse the rate at which they're dying. That's kind of programmed into the genetics of the problem. And so it does not really stop the disease progression. It was thought early on that maybe it had some neuroprotective effect, that you could throw one of these electrodes in and maybe you can slow down how fast the disease goes, and we've essentially shown that that's not true. So it really should be performed when the symptoms are not well managed through medication and the quality of life is substantially impacted. So what is too early? Well, there's a list of controversies. If you've not received a standard of care for medications, or your diagnosis has been for under 5 years, you're not having motor fluctuations, or, and this is one of my favorite ones, I don't like to take medicine, doc. So rather than take the medication, what you'd rather have is brain surgery and try to stop the medication early on in the disease. Now, I get it. I don't like taking medication either, but not necessarily the best strategy. Or, the patient has been diagnosed and they have non-disabling or non-bothersome dyskinesias. Another common reason is, especially if you're diagnosed early in your 50s, want a DBS to continue employment because some of the side effects of the medication make it difficult, particularly depending on your job. And then again, patients who are DBS works best for some of the motor symptoms of Parkinson's disease. There are a lot of other troubling symptoms of Parkinson's disease, like we mentioned before, and folks that are seeking improvement in those symptoms and not in the motor symptoms. Now, these are not sort of taboo. It's just one of those things where you have to have a conversation with people, and that's part of why I like this job. Is you can't just come in now. You need a new hip or you need a new knee. You have to actually have a detailed conversation of what people's expectations are, what they're looking to get out of this surgery, what impact they're hoping to have, what is their real goal. And most people will tell you, oh, my goal is to get rid of my Parkinson's symptoms. But if you sort of dig a little deeper, there's a bunch of other goals in there too. I want to keep working. I want to be able to play with my grandkids. I have one fellow wanted to get his black belt in karate. Those kind of things. Actually, it was Taekwondo, if I remember correctly. Anyway, too early, yes, I think that if you haven't tried some of the medications and you haven't really exhausted that, then we are talking about brain surgery. So you have to talk about the risk-benefit profile of a deep brain stimulator, and it's reasonable to try some of the medications, particularly as more and more become available. So the 5-year cutoff may seem a little arbitrary to some people. I mean, what is 5 years? Why not? If I have really bad Parkinson's disease at 2 years, why not get it early? Part of that has to do with Parkinson's disease. There are tests like DAT scans and other tests that we can use to try to help us decide whether, in fact, you do have kind of a clean Parkinson's disease. There are other Parkinson's-like syndromes that involve a lot of other symptoms, and they're not quite Parkinson's disease, and they don't quite respond to deep brain stimulation the way you would like. And so having at least some time in the diagnosis to sort of get a sense of where this problem is headed is helpful. It takes time for it to fully evolve and to sort of see from a surgical standpoint where you're going to stratify. And there's no way to identify folks who might never need surgery. There are trajectories to Parkinson's disease where it doesn't change for a really long time, 10, 12, 15 years. And then all of a sudden it starts to worsen. There are folks that it starts to get bad right away, and there are a bunch of folks in between that. So you sort of want to get an idea of where this person's disease is headed. So if you're looking at somebody that's only been diagnosed for 2 years and they're thinking of a deep brain stimulator, but they haven't really changed, their medication requirement hasn't changed, it may be that they could go on for a long time without having that medication change, without worsening. Too late is a little bit more clear. If you've waited for the medication now is no longer effective. You can't be put in an on state. You don't respond to the dopamine. The non-motor symptoms have kind of taken over the game, or there's been significant cognitive decline. Then that's a bit too late. And so it's this kind of balancing act where you're trying to evaluate, whether or not too late is usually easy to eliminate pretty quickly. Those folks are easy to recognize in some experience. And you want to not do too early, and then everybody's in between, and you're trying to gauge where on the spectrum the person in front of you is going to fall. So when talking about when the medications start to wane in their effectiveness, it is the rare Parkinson's patient that walks in and signs the papers for brain surgery on the first visit. I don't particularly care to do that myself. I'd like to get to know people a little bit, so it might take 2 or 3 visits. What usually happens is they'll come in at some point when their neurologist thinks that it's an appropriate time to start having the conversation. And then, we'll have a conversation and you'll get a little slideshow kind of like this. And then go back and think about it. And then they might come back 3 or 4 months later, and I've thought about it, and I have this list of questions, and we go through the questions again, and okay, then at that point, I have a social engagement, or the holidays are coming up, and I might want to do this next year, and I'm not sure. I'm like, that's great. And go on and come back, and they'll come back another time, and at some point down that line, I've had folks that'll show up regularly every year for the first few years and just checking in to see if there's anything new, and that's all fine. You kind of need to develop a relationship so that we can understand what it is you want to get out of this and get to know each other a little better. And then once we've figured out what that, in fact, it's an appropriate time to consider this, then there's a bunch of technical issues that the neurologist and myself sort of have to talk about, which target. I tend to favor subthalamic. These abbreviations, STN is subthalamic nucleus, GPI is globus pallidus internus. They're just fancy words for structures in the brain in that circuit diagram that I showed you in the beginning. STN, we think, does a little bit better tremor control. Globus pallidus does a little bit better dyskinesia control. Globus pallidus has a little bit less of a dementia issue, and there's greater medication reduction for STN. There are some, cognitive mood issues that have been documented with STN. They're not very common, and there's less speech issues with GPI. So there's a different, again, we're trying to tailor this to you, and so there'll be a different target depending on what we think. STN is by far and away a bit more common than GPI. So what do these leads look like? Well, what is a lead? Let's start with that. Well, a lead is just a really small wire, insulated most of the way down, and has 4 collars on the bottom. And those collars can emit electricity. You can make them positive or negative, and you get this little sphere of electricity. And by changing which ones you have positive and which ones you have negative, you can shape how the electricity is developed in this little target. That little target, say for instance, might be the subthalamic nucleus. And so what you're trying to do, the way the stimulator works, is you stimulate these nerves, these neurons in your brain at such a high frequency that it shuts down. So you probably remember way back in biology class, they would have you take a little frog and stimulate his muscle until it stop working, right? So the muscles do that, nerves do that too. So if you stimulate them too fast, they'll shut down. And that's, of course, what you're trying to do, because then the nice thing about it is when you turn off the electricity and you're no longer stimulating that nerve too fast, it starts working right away. So that's how we do it with a DBS lead. And we can kind of control where we're stimulating based on where on this column what contacts we use, etc. And from a bird's eye view, this is what it might look like. You might get a little sphere of electricity around the deep brain stimulator contact. There have been some innovations in this market. One of them is to get leads that now, if you take, I'm going to go back a little bit here. If you take this collar and you break it up, you segment it so that if you think about it from a clock, if you had, say 3 of them, here from 3 to 5, and then skip, do another little collar here, another little collar here, you might be able to directionally change where that field is going to go, and that's what this might look like. So rather than have one sphere, you can stimulate 2 spheres, kind of trying to get more area in that target and see if that doesn't give you a better clinical effect with less side effects. Again, the whole idea here is to try to tailor how we put a lead in, where we put it, what side effects and what benefits we get out of it. So unilateral versus bilateral. Again, for those of you who are not familiar with the terms, one side versus both sides. Again, both STN and GPI have we tend to do those bilaterally. You can do unilateral targets. If you're using GPI, we tend to do a little bit better in terms of just using one side, but you can also do a unilateral STN lead. most times we try to choose bilateral when we can. We tend to fall back to one side when we think we're going to end up with a problem. Generally, that problem has to do with cognition. And this is my favorite one. Now, I'm going to walk you back in history. Staged versus not staged. What does staged mean? Staged means that traditionally deep brain stimulation surgery was done awake, and it was done one side at a time. And so that meant you got one lead in your brain, and then you came back 2 weeks later and you got a battery, and then you went back again and got another lead in your brain, third surgery, and then you went back and got another battery, 4 surgeries. That evolved over time to 2 leads in the brain, and then come back at some point later and do the battery on one side. The fewer stages you have, especially as you're working on older folks, the less anesthetics you have, the less potential, in my opinion, for complication, and I'll show you what that bears out to be. It allows for shorter OR time, which becomes a little bit more important if you're awake, if you're doing it staged. If you're not doing it staged, again, you're talking about one surgery, one frame on your head, and it's a little bit more comfortable. It's a little daunting from a purely marketing and selling it to you standpoint to say, yeah, we're going to fix your Parkinson's disease, but you're going to have to go through 4 surgeries over the course of whatever, a year. As opposed to if I say, we're going to do 1 surgery and you're going to be done. When we first started this, there was a lot of research going on. We were doing a lot of recording, that is listening to the nerves as we put the leads in and learning a lot. So the staged DBS had its place. When I started doing this 16 years ago, we were doing them all staged and all awake. Now we've gone to doing them mostly not staged and asleep. The nice thing about a staged surgery from the standpoint when we were doing it awake is the patient was awake, and then you either had to let them go home, which is what we preferred, or you had to put them asleep. Well, when you just put a lead through the brain, it's a little scary to put them asleep. You don't know what's going on. You don't know how they're doing. You don't have any way to assess that, and you got to put a battery in, and then you wake up, and if there's a problem, you don't get to learn that until they're coming out of anesthesia. So that was the logic for doing it staged. Now that we do them asleep, again, we have a shorter time. In the OR, we have 1 frame placement and 1 anesthetic. And so some of that innovation has to do with what we're going to get to in just a minute. But it's a balanced. If you're a fragile patient, or if there's something that we're worried about hemorrhage in the brain, we're worried about your overall cardiac function, we might choose to do shorter staged procedures and do them more frequently rather than a longer not staged procedure. This is how we, just is how we kind of do a DBS. First, there's a head ring that goes on. I'm going to show you pictures of all this. Then we plan where we're going to put the electrodes. We drill a hole in your head, and we go ahead and we put the electrodes in. And then often, if you're doing it awake, we'll ask you to do some things. And do I still do them awake? I do 98% of my surgeries asleep now. There's an occasional folk that I will do it awake for. The last person I had who was a violinist, he wanted to be sure that he could use his violin. His violin was very expensive. We do not allow that in the operating room because we don't want it to be broken. But a laser pointer serves as a handy model for how steady you can control your hand. Then we secure the lead in place and close, and then we would come back at another time and connect to a battery. So the biggest thing in DBS surgery most recently is doing it asleep versus awake. I'm going to start with awake. That's traditionally how we did those. And what we did is something called microelectrode recording, which is rather than putting the deep brain stimulator wire down first, we would take this fine listening electrode and listen all the way down until we found the target. And there was a signature that this target had. So if you record different parts of the brain, it's not surprising to you that they all sound a little different and their electrical signature looks a little different. Well, one of the things that I spent all this training time learning was what those little areas look like and sound like. And it's bizarre because not only can you kind of see it, but if I were to show you these recordings, you'd think they all look the same. If you actually listen to them, they don't sound the same. And in fact, I can tell you that the SDN, for instance, sounds, you can hear it coming like you can hear a swarm of bees coming. As you sort of start to get close to this thing, it has this kind of buzzy. Anyway, that was useful stuff. It allowed us to figure out where in the brain we were physiologically. It allowed us to map it out. And it allowed us for intraoperative testing because you were awake. But it did lead to longer operating room times. When you do something awake, you're going to listen with the electrodes, you're going to test the patient, you're going to put one lead in, and you're going to go to the other side, you're going to listen with the electrodes, test the patient, put another lead in, and you can push the operating time up to 5, 6, 7, 8 hours sometimes, and that's a long day when you're awake. One of the biggest innovations in neurosurgery in general and in functional neurosurgery in particular is that we started to get some very sophisticated imaging equipment in the operating room. And those imaging equipments included things like ultrasounds, CT scans, and MRI scanners. We here at St. Joseph's have one of the first diagnostic intraoperative CTs in the country. And we used it very effectively for not only deep brain stimulation surgery, but just about everything I do, like spine surgery, putting screws in the spine, fixing broken necks, that kind of thing. And what that allows us to do is we can get a preoperative MRI scan or image, and we can get an image, a CAT scan, and you can use this image technology in the fancy computers that we have to meld them together so you have it all on one workstation. And that allows us for intraoperative imaging. And we can kind of precisely dial in our coordinates. We can check where we want to go preoperatively. We can then put the electrode in, and we just get another CAT scan. And we can find out whether or not there's been any bleeding and whether or not the tip of that electrode landed exactly where I want it to land. And the good news is that there are clinical studies now. Francisco Ponce up in Phoenix has got something like 1,600 leads over 600 patients that shows that the accuracy when you use an intraoperative imaging device such as a CT scanner and MRI is exactly the same. His model and my model down here is a CT scanner, is exactly the same as if you were to do it awake and do neurophysiologic monitoring, and it's faster, it's just as safe, and it allows for corrections as well. So you get a shorter OR time, and it's easier to do both leads in the generator in the same sitting. So why is that? Well, if you're already asleep and I have the ability to look inside your brain and know that everything is okay and there's no bleeding, then I feel a lot safer with proceeding to the next step. And that's the generator placement. The generator placement only takes about 30 to 40 minutes to do, but it's nice to be able to have the option of being able to look with a CAT scan anytime you like. And this is just a couple of the papers from Ponce's study. This is what our system here at Joe's looks like. And I'm going to kind of walk in front of the screen here a little bit. This little guy is an intraoperative CT scanner. Now, CT scans weren't invented here, of course, but one of the nice things that one of my partners did is he figured out how to put it on a rail. So this thing can slide out over the table and get an image of the head or spine or any other body part that we want. And it's just as accurate as the CAT scan that we would use postoperatively. So if you came in and you had a DBS 2 years ago and I wanted to know where those leads were, I would either do an MRI or a CT, and I would use that kind of a scanner to do it. So it allows us to check in the operating room with just as much accuracy as we would out in the real world. All the other stuff you see in there is some of the fancy computerized equipment. There's what's called a navigation device that allows us to register that CT scan to an array that's placed on the patient's head or in their spine. So we can use computer modeling to accurately place any kind of device that we want. This is what a deep brain stimulation case looks like. You can imagine, you can look at how accurately the patient's head is recreated. You can almost, if you knew them, you would recognize them. That's why their name's not on it. And at the same time, you get to see the inside of their brain with quite a bit of accuracy. Those little green lines, the trajectories I've chosen to target. In this case, the target is STN. And this is what the brain in the box thing looks like. So here's somebody in our CT scanner with their brain in this frame. Why the frame? To those who are engineers and mathematicians here in the audience, Why do a frame? The brain is this sort of big round blob of something that you have to kind of put a measuring system on in order to find out where you want to go. So if I want to target right there, how do I get from outside here to this little tiny target inside your head? Well, it would be nice if you had a GPS, right? And that's what that box does, is it puts a grid in 3 dimensions on the brain, and then you can pick the point that you want, and it will tell you the 3 coordinates that you use to get there. And then you can sort of start anywhere on the outside of the head and drive your electrode right down to that target. And again, same person now with the frame on. So we did a scan beforehand. That was an MRI. This is a CT scan. You can see the frame represented on the outside of the patient's head, and those lines again will tell us exactly where they are. Now what we're going to do is we're going to ask the computer, okay, this is where we want to go. Tell us what the coordinates are, and it will tell us exactly where it is. And then we're going to say, okay, I want to pick my entry point up here, draw a line from here to here, tell me how long it is and what angles I need to take to get there, and it will do just that. And this is what it looks like when we do real-life surgery. And there's the CAT scanner doing a follow-up CT. What is this? This looks like the same picture all again, not quite. We've introduced up here in the upper right-hand corner 2 little white dots. You'll see those little white dots are at the very bottom of that line. That is what an electrode looks like in cross-section. And so I can track that electrode all the way out on my post-lead placement CT scan. So, again, why do DBS? Well, the easy answer is that most people who get a DBS find it very life-changing. 96% of folks would recommend DBS therapy from a patient standpoint. From a clinician standpoint, I can tell you that this is often one of the most enjoyable things I do. Spine surgery is hard. Deep brain stimulation surgery is hard too, but it's very satisfying. Patients are often very thankful. Their tremors controlled, they're moving better, they're functioning better, they're able to take care of themselves. It is one of the more satisfying things that I do.